Yeah, I can see the camels and
camels.
the wonderful.
Yeah.
Oh,
So I
great.
do go visit the from time to time. So next time I visit, probably
Definitely we'll make it
I
sure
will
that to
search.
visit. Oh, wow. Jodhpur is a
Yeah.
lovely place. It's,
You know,
it's great.
that's one of the cities in Rajasthan which I haven't seen. I've
Okay.
traveled within Rajasthan quite a lot, but Jodhpur is not one of the places that I have been so far.
Right. So possibly because it's far away from Udaipur and Jaipur and Jaisalmer too. So people like to do the touristy things, and if it's home, only then they do come to Jodhpur. But so it's going to be wonderful. We'll make it sure you come
Yeah,
here.
yeah.
Yeah.
So
I've often heard you,
and
but I never thought, I'll get to introduce you on a pod. I mean, it's great.
yeah.
It's so
Um,
nice. So,
yes, I think there was supposed to be a meeting in Jaipur some time ago, and I think they were trying to organize something, and unfortunately, it didn't work out with my schedule, and I couldn't go there. But visiting any of the places in Rajasthan is always a big plus for me, because there are few places where I don't need any invitation, because they are like home to me.
yeah, great,
Yeah.
wonderful. That's great. No, and Jodhpur, it has many touristy locations, and otherwise it's very
Mm,
friendly. The people they're
mm,
really nice and peace loving. I mean,
mhm,
it's quiet. It's not like a metro, and
mhm,
it's
mhm.
quiet. People say it doesn't have a mall culture. We are very comfortable with that. I would say
Yeah.
that.
And where were you before you came to
We are
Jodhpur?
on time to start. Can
Sure.
we start for
Sure.
just give me a minute, right? Yeah, it's 7:30, right? Good evening, everybody. Welcome to this evening episode of Pursue. And today we have Pursue 6X Liver and GI Pathology. We are streaming live from Yale University School of Medicine, USA via Kolkata. And we have two very special people here. First, let me introduce the moderator, Dr. Poonam Abhay Alliance. She's an MD, DNB, a postdoctoral fellowship in cytopathology from PGI Chandigarh, a professor and head in the Department of Pathology at AIMS Jodhpur, a very, very well-known person, and she is going to introduce the speaker today. So let me ask Dr. Poonam, ma'am, please introduce the speaker and take it up from here. Thank you so much.
Thank you so much, sir. I mean, I don't think Dr. Dhanpat Jain really needs any introduction to the pathology people anywhere in the world. It's a privilege and an honor for me to be, introducing sir on this forum. Though it's like chota muh badi baat, but for those of us who are very young, possibly, I mean, I would like to tell that sir is a professor of pathology and internal medicine, the section of digestive diseases. He's also the director of program in gastrointestinal pathology at Yale University, USA. He graduated from Mysore Medical College, India, and received his MBBS in 1986 and his MD pathology from the Temple of Learning, Pgimer, Chandigarh, in 1991. He moved to the US in 1995, completed his anatomic pathology residency and fellowship in GI Path at Yale University School of Medicine, where he continues to be a faculty after his fellowship. He's a nationally and internationally recognized GI pathologist, known for his diagnostic skills, his research, and teaching. He has he has innumerable publications, many book chapters, books and reviews, largely in the field of GI cancer and liver path. He has delivered many lectures and participated in many courses at the national and international level. He's on the editorial board of several high-impact journals in the field of GI and liver disorders. His area of expertise is motility disorders of the GI tract, for which he gets cases from across the globe. He's an accomplished teacher and has received many awards. He has continuously been nominated for Best Doctors in the US for many years. So with that, I would not like to waste any time, and I would like to invite Professor Dhanpat Jain sir to kindly take over and start his presentation. Thank you so much.
Sure. Thank you, Poonam. Thank you for so much for this very generous introduction. I have to say that it's always a pleasure and privilege to present or give any talks to all the audiences in India. I wish I was doing this in person, but given the current situation, I think this option is not bad. I have to say that there are many people that I can already see in the audience that I have met or known, and it's a great pleasure to have all of you in the audience, and I hope you enjoy this topic. Today I'm going to talk about some conditions which are a little uncommon, but again, I think once in a while you'll see them in practice, and when you see them, they can be fairly challenging because, as you know, most of the cases that come to you come as really truly unknown, and they don't come with the diagnosis written on their face. Of course, when you see them in a conference setting or sometimes in your test sort of scenario, probably they pose less of a challenge because you know that you are dealing with a complex case, and it is some kind of a zebra, and your mind is racing in that direction. But in real life, these just sneak by under your microscope. And if you're really not paying attention, some of them are easy to miss, number one, and some of them are rare that sometimes you don't even think about them. So I think the goal of today's lecture is to give you some idea about some of these rare disorders that can come across your table, as well as give you certain hints or clues as to what could be the key feature or key point when you're dealing with these cases that leads you towards the right diagnosis. So with that, let me start presenting my lecture.
Yeah.
1 second. So this is something which I've done in the form of case presentations, which is fairly realistic, and all the cases that I'm going to show are real cases. They are not taken from any other book or some other website. These were all real cases that I saw over the period of years, and that things that you see are fairly realistic and can happen to you or anybody else in clinical practice. So start with this case, which is the main case that I wanted to kind of present, and via this case we'll talk about other entities that are the differential diagnosis and highlight one of the kind of broad areas of G I Polyposis syndromes. So this particular case was a 80-year-old female who presented with long-standing diarrhea for 9 months, and this diarrhea was really troublesome and was serious, and as a result, this patient had significant weight loss, 30 pounds in 6 months, and eventually had low albumin, developed edema, and other changes that were secondary to some form of malnutrition that included hair loss and nail changes. At this time, the patient went under endoscopy. And the most interesting thing was that numerous polyps were found throughout the GI tract that included the polyps in the stomach and duodenum and even in the colon. Interestingly, this patient never had any endoscopy or colonoscopy prior to this one. So if you look at the timeline of this patient, just putting this in perspective, started with diarrhea, and after 6 months had developed edema, and subsequently developed hair loss and nail changes, and at this time the weight loss was significant. And here you can see the endoscopic pictures from colonoscopy and upper endoscopy, and if you can see in the upper endoscopic pictures, these are from the stomach and the duodenum, and you can see numerous polypoid lesions. And if you pay attention, these lesions are sessile in nature. They are raised from the background mucosa. They look somewhat inflamed, and the mucosa has a somewhat edematous look. You can see the same thing in the duodenum. And if you look at the colonic polyps, the polyps are fairly impressive. Some of them are fairly large, but they look all generally sessile, and also pay attention to the intervening mucosa between these polyps. So the biopsies were performed from these polyps, and actually the biopsies that we saw were less impressive than the endoscopic picture. This is the biopsy from the stomach, and what you can see is the surface foveolar epithelium, which is sort of slightly reactive looking. In this area, you don't see any of the antral or oxyntic glands, but you see some degree of inflammation in the lamina propria, which is lymphomononuclear kind of infiltrate. You see some degree of edema in the lamina propria. That's why these glands are separated. Otherwise, you don't see some of the features that you generally look for in polyps, particularly any evidence of dysplasia in the lining epithelium, nuclear atypia, stratification of the nuclei, all this kind of stuff. This is the biopsy from the colon. Again, the key features are highlighted here. There was sort of edema in the lamina propria. There was lymphoplasmacytic infiltrate in the lamina propria. The crypts were largely non-dysplastic. There is some loss of mucin, which you would expect with inflammation, but by and large, these are not adenomatous crypts. These are not dysplastic crypts. So that finding suggests right up front that this is not one of the adenomatous polyposis syndrome or anything which is similar and in the differential diagnosis of adenomatous polyposis syndrome. So these polyps are non-dysplastic polyps that at least are characterized so far by looks like a lot of inflammation in the lamina propria. This is another biopsy from the colon, again showing some distortion of the glandular architecture. They are all funny shapes. There is some loss of mucin in some of these crypts. You can see areas of even cryptitis. In these areas, the crypts look really very reactive, but this is still not dysplasia. And these crypts may be slightly dilated, and they have some luminal secretions inside. So that kind of generates a host of differential diagnoses. However, some of the polyps, actually I would say two of the polyps in this case also showed the dysplastic epithelium. So this is one of them. And here, in contrast to the other things that you saw earlier, you can see these crypts that are dysplastic. They have adenomatous epithelium, again, that is unequivocal. This is something that we will call a tubular adenoma or adenomatous polyp. The background mucosa, again, shows some of the features that we already saw in other biopsies with a lot of lamina propria inflammation and some, cystic dilation of the glands and some reactive changes. So, with this, I think the differential diagnosis that we came up with was as listed here on the screen. We thought of juvenile polyposis, which can have all those features that I illustrated, and other hamartomatous polyposis syndromes, basically, that include Cowden Syndrome, Peutz-Jeghers Syndrome. This also brings in the differential diagnosis of inflammatory polyps in the setting of inflammatory bowel disease, ulcerative colitis or Crohn's disease, and lastly, a very rare disease which is Cronkite-Canada syndrome. So these are the sort of main broad categories that one needs to consider in this setting where you have numerous polyps involving the entire GI tract. The only part that was not involved was the esophagus, basically, and these were, like back-to-back polyps carpeting the entire luminal GI tract. So with that, I would say that right off front, one can say these probably do not represent IBD, because in IBD you tend to see the polyps usually in the involved segment of the GI tract, either colon, very rarely in small bowel, and involvement of stomach and duodenum like this probably will be extremely unusual. So I would say that this probably is very unlikely, and this patient clearly did not have any history of inflammatory bowel disease that we knew of. So why do we need to know about these all polyposis syndromes? So that is important because as we know, especially from Adenomatous polyposis syndrome, that patients have a very high risk of colon cancer. In fact, with Adenomatous polyposis, the risk is almost 100%. Once you encounter some of these polyposis syndromes, you have to know the risk of colon cancer that these patients have, and any other associated cancers that these patients may have. But however, when you put this in perspective of colorectal cancer, one has to recognize that 95% or more of colorectal cancer that we see in practice is actually sporadic, and only about 5% of cases are associated with some syndrome. So while the syndromes are very important, we need to know about them, we need to understand the pathophysiology and all the associated stuff, they actually constitute a very small percentage of colorectal cancer patients. And even within this group, Lynch syndrome constitutes almost more than half of the patients, and other syndromes constitute really a very small proportion of patients only. If you look at all the polyposis syndromes which are listed here, you can divide them into few major groups. The most common and the one that everybody is familiar with is the Adenomatous polyposis syndrome. And in this there are many variants, and there are other things that considered under Adenomatous polyposis in some ways, but are distinct syndromes. For example, Lynch syndrome that has adenomatous polyps is characterized by not numerous but many adenomatous polyps in these patients, and sometimes even called non-polyposis cancer syndrome. But one need to understand that under this category, all the syndromes, when they have the polyps, they are all adenomas. They are all dysplastic polyps. And this is one group. Then there is a group which is comprised of polyps that have some variation of the or some members of the serrated polyps as the main feature. And in this serrated polyposis syndrome or hereditary mixed polyposis syndrome are included. And this is the most interesting category, which we call the Hamartomatous polyposis. And this is what we are going to discuss today. This is certainly not common, but again, you will see some of these in your practice if you practice long enough. This includes Juvenile polyposis syndrome, Cowden syndrome, under which there is a sub or variant which is called Banyan-Riley-Rubel-Cava syndrome, Cronkite-Canada syndrome, and Peutz-Jeghers syndrome. The interesting thing is that while in adenomatous polyps and serrated polyps, all the polyps under each category are fairly similar and uniform in their morphology, here in Hamartomatous polyps, the polyps under each category have some similarity and many other differences. And that is important to know. And once you recognize the similarities and the differences, coming to the right diagnosis in this setting is often not that difficult. Besides this, there are many other miscellaneous categories that some of them have been recently described, like gastric adenocarcinoma associated with proximal polyposis or GAPS. This is something that is really understood in last 5 or 10 years, and still people are not very familiar with this syndrome. And there are still things that we're learning about this syndrome. Besides this, there are other rare syndromes where you have mesenchymal polyps in the GI tract, which can be numerous. These include inflammatory fibroid polyposis and lipomatosis and leiomyomatosis, where either you get lipomas or multiple leiomyomas. So today, as I said, we will talk mostly about Hamartomatous polyposis syndrome, which was the differential diagnosis in this particular case. And the first thing is, what do you mean by hamartomas? This is something that we learned fairly early on, either in medical school or pathology residencies, that hamartomas are considered as mass lesions that result from a disorderly proliferation of tissue elements normally present at that site. Conceptually, these were thought to be all developmental in origin, when you talk about hamartomas in the GI tract or intestine, these usually are composed of disorganized glandular or crypt structures that show varying degrees of reactive changes or hyperplasia or cystic change, and are admixed with smooth muscle of the lining. These often also show inflammation and fibrosis, but these are probably secondary in nature in most of the lesions. The important part to know is that while these are non-dysplastic to start with, many of these do develop dysplasia and cancer subsequently. And although it was thought that these hamartomas are malformations and congenital in nature, now many of these so-called hamartomas have been shown to be acquired lesion, or if they're congenital, they're associated with genetic mutations, and some of these lesions are now even thought to be benign neoplasms. At least in the GI tract, the Hamartomatous polyposis syndrome, all of them have now been associated with germline mutations that we will talk about, except for one rare condition. Understanding the genetic underpinning of these lesions really poses the question: are these truly malformations, or these are neoplasms? And that puts a big question mark on all kind of hamartomatous lesions in general. So, of the things that we discussed, one of the conditions is so-called Cowden Syndrome. This was named after the family in which this disease was found, and it was described by Lloyd and Dennis in a case report initially. This appears to be very, very rare, and while the incidences are quoted in books as like one in about 200,000 population, in our clinical practice, probably people will see this, in their lifetime at least few times if you practice long enough. I have probably seen, at least 4 or 5 cases of Cowden syndrome by now, and I have been practicing for about 30 years. So these are certainly rare, but you will come across these cases in your practice at some point of time. This is an autosomal dominant genetic disorder, and as is true for many of these syndromes that we're talking about, is characterized by various hamartomatous growth and increased risk of certain kinds of cancer. While many of these syndromes are passed down from the parents to the offsprings and are familial in nature, many of them also occur de novo. And that's also true of Cowden syndrome, that de novo mutations are fairly common. The interesting thing about this particular syndrome is that unlike many others which predominantly affect the epithelial layer or the things that are arising from the endoderm, this particular one has lesions that arise from all the 3 germ layers, as we know. The other interesting finding about this particular syndrome is that while these are all GI polyps. These are generally fairly small and they remain asymptomatic throughout the life of this patient and are detected largely during screening colonoscopy or when the colonoscopy is performed for some other reasons. The GI involvement is fairly frequent in this syndrome to the tune of 35 to 60% of cases, but it also means that all patients of Cowden syndrome do not have GI involvement. GI involvement can occur or can be seen in all segments of the GI tract, including esophagus, stomach, and small bowel and large bowel. The lesions that you see in this syndrome are highly varied, and this is another unique thing about this particular syndrome. All the polyps that are seen in this particular condition are very, very different from each other. And sometimes presence of all those things in one person probably is one of the biggest clue that you're dealing with probably Cowden syndrome. For example, in esophagus, the typical lesion that you see in this condition is glycogenic acanthosis, which is just increased glycogen in the superficial layers of squamous mucosa. In the stomach, you see foveolar hyperplastic polyp, virtually identical to what I showed you in this particular case that I started with. In small bowel and colon, however, you see a variety of a mix of lesions. These can be ganglioneuromas mixed with juvenile type polyps, and I showed you some of the lesions that really look like juvenile type polyps in the case that we're discussing. In addition, you can see lipomas, fibrolipomas, and also tubular adenomas, which we saw in our case as well. Many patients present with extra GI lesions, and often that is the mode of presentation of these patients. And most of the patients will manifest by the age of 20 years. Among the extra gastrointestinal manifestations, there are many, and these are listed here. Patients can get mucocutaneous lesions, which include tricholemoma, acral keratosis, oral papilloma. In CNS, dysplastic gangliocytoma can be seen. The patients may have goiter or thyroid adenomas, and there are a variety of skeletal abnormalities that may be associated in these patients. So this is an example of Cowden syndrome that I saw in my practice. This was a 52-year-old male who came for screening colonoscopy and was found to have multiple 50 to 100 kind of range polyps, which are fairly small and mostly sessile that were present in the colon. Few small lesions were also seen in the duodenum, stomach, and esophagus. And here in the esophagus, you can see this kind of pale plaques. These are described as whitish or pale yellow plaques in the esophagus, which is characteristic of glycogenic acanthosis. These were those kind of polyps seen in the stomach, and colon, as shown here, also showed multiple tiny sessile polyps. This is one of the colonic polyp, and what you can see in this lesion is that the crypts largely appear normal. They are non-dysplastic, but they are sort of slightly disorganized, and they're disorganized because there is a proliferation of something in between them. And if you look carefully, this looks like basically a spindle cell proliferation with some admixture of inflammatory cells. And if you pay attention, you might see some large cells like this here, here, and in this area you can see a cluster of those cells. So at the low part itself, we can start forming an idea as to what this lesion might be and where to actually focus. If you look close, you can see that the cells that I was pointing to, which are very large cells, all look like ganglion cells. Now you can also see the spindle cell that I was talking to you about appears fairly bland. They don't have any kind of particular arrangement, but you can see that they may have some suggestion of neural-like features. In addition, there is a fair sprinkling of lymphocytes and plasma cells in the background. At the same time, note that the crypts, besides showing some loss of mucin or slightly reactive appearing, are completely non-dysplastic. And by now you would have guessed that what you're seeing is actually a ganglioneuroma. Although you don't need any stains to kind of confirm that, but it's always nice to demonstrate that. S100 stains certainly highlights the neural fibers in the background, the spindle cell proliferation that I was talking to you about. And these are the ganglion cells, which also stain for S100 stain. You can use other stains as well, but the morphology of these ganglion cells is so typical that you really don't need an immunohistochemical stain to kind of identify those. In addition to that, ganglioneuroma, there are other variety of things that were present in those polyposis or the polyps that were sampled. This is a lipoma that was identified. Some of the lesions had just lymphoid complexes and nothing else. And this is the biopsy from the esophagus, which shows increased glycogen in the superficial layers of the squamous epithelium, which is typical of glycogenic acanthosis. And this is the hyper of the squamous epithelium showing increased glycogen. And as I mentioned, these appear as pale white or slightly light yellow colored plaques in the esophagus. And you can see many of them here. In addition, some of the polyps had the features of hyperplastic polyp, which were also admixed with the other things. So, as I said, that one of the features of this polyposis is that you get mixture of different kinds of polyps, which is not typical of any other kind of syndrome that I know of in that sense. The other thing was that I could have easily missed the diagnosis because none of the polyps were so-called very characteristic or something that by itself will bring the possibility of Cowden syndrome in my mind. But the key thing was that the clinician had seen multiple polyps, 50 to 100 polyps in this patient. So it was clear that he was dealing with some form of an polyposis syndrome. And when you put that along with the kind of polyps that we see in this particular case, it was fairly simple that this was possibly a Cowden syndrome. And nowadays, we have a better understanding of the genetics of many of these syndromes. The Cowden syndrome has now been associated with mutations in the PTEN oncogene, and it is in about 85% of cases, of which, again, about 1/3 are familial in nature. The other thing that one needs to understand about this polyposis syndrome and some others is that many of those which are characterized with the dysplasia in the polyps do have risk of colonic carcinoma. This is one of the syndromes which is characterized by polyps in the GI tract, but has very minimal or probably no risk of GI cancers. All cancers that occur in these patients are actually all extra gastrointestinal, and the cancers that one needs to be aware of in these patients are listed here. These include breast carcinoma, thyroid carcinoma, endometrial carcinoma, and many other less common types of cancers. And as I mentioned, the cancers in the GI tract itself are actually very minimal or probably not significant. And probably when they occur, they are largely incidental in nature. And now what we have also recognized with understanding of genetic mechanisms of many of those syndromes is that, we used to recognize earlier many of the syndromes by combination of findings that we used to see, and these were all given different names. Some are listed here, Cowden syndrome being one of them, Banyan-Riley-Rubalcaba syndrome. These are such, long and sort of tongue twister names that sometimes it is difficult to even remember which one is what. Proteus or Proteus-like syndrome, Hermit-Douglas disease. So there are many different syndromes which now have been all shown to be related to mutations in PTEN oncogene. And there is a movement to rename all those things as PTEN polyposis. To make sure that we are talking about the same kind of disease and not distracted by the different names that people have given to these lesions in the past. So that's one syndrome that one needs to keep in mind, and some of those cases will slip by your microscope if you're not paying attention. And the key thing is you have to know the clinical setting as well as the histology of various polyps that you see in that setting. So let's move on to the next important Hamartomatous polyposis syndrome, which is Juvenile polyposis syndrome. These typically present by third decade in the patients. They present with bleeding or GI bleeding rather, intussusception because of polyps in the small bowel particularly, and when there are numerous polyps, they can have protein-losing enteropathy as well. The polyps themselves can be very varied grossly. They can be sessile, small, to fairly large and pedunculated polyps, and we will see some examples of those. Histologically, these lesions are characterized by disorganized crypts, which are distended by retained intraluminal secretion, which is mostly mucin, and often inflammatory cells, and these can become cystic. And that is the characteristic feature of some of these juvenile polyps, that cystic dilatation of many of the glandular structures of the crypts. These are often heavily inflamed with areas of ulceration, and the inflammation can be fairly mixed and very, very prominent in some cases. Overall, these polyps can develop dysplasia and carcinoma, with the risk of colorectal carcinoma in this patient estimated to be about 23%. And based on that risk, many of the patients at certain stage may undergo prophylactic colectomy as well. Variety of diagnostic criteria have been kind of laid down for this polyps, and you can actually look at any of the reviews or textbooks for those. I'm not going to go on details about each one of them. The key thing is that whenever you see multiple of these polyps in a patient, especially in the setting of a family history, you should think about juvenile polyposis. The genetics of this polyposis syndrome has also been kind of understood in last couple of decades now. This is something that has been associated with SMAD4 or MAD4 gene, or mutations in the BMPR1A gene. These can occur in both familial and sporadic forms. And these polyps, if you think, the juvenile polyps, and I am pretty sure that all of you have seen these polyps in patients who have otherwise no polyposis, as isolated single polyps. And these frequently occur in children. In fact, in children, this is the commonest type of colonic polyp that you see, usually between the age of 1 to 10 years, with no sort of gender predilection. And in kids, these are usually seen as very inflamed, ulcerated polyps that are sent to pathology, almost what people describe as cherry-like polyps because of the red color. These polyps, which are described as juvenile type, or sometimes we also call retention type polyps, can be seen not only in juvenile polyposis syndrome, but can be seen in other type of polyposis syndrome itself. So this is one of the polyps which is by itself not diagnostic of a particular syndrome, just looking at one of them in a given case. You have to look at everything else as well. I'll show you an example of juvenile polyposis syndrome. And this is a patient who presented to us when he was 40 years ago. When he was 40 years of age, and at that time we did not know, but afterwards we found out that the patient already had undergone total colectomy at the age of 20 years. We saw the patient in our department when he had presented with upper GI symptoms, and develop protein-losing enteropathy. Endoscopy at that time showed numerous polyps in the stomach with very thick folds, and because of all the symptoms and various other factors, the patient underwent total gastrectomy. As I mentioned, the patient had already undergone total colectomy. So, as you can imagine, after the gastrectomy, what he had left was just esophagus and part of the small bowel. So, this is the stomach from this patient, and what you can see here is some polypoid lesions, like here. There is a lesion that looks a little bit different, and you can also see very thick gastric folds in the background. In this area, if you see these things almost look like finger-like projections or villi of small bowel, except that these are really large and very edematous. So there is a variety of changes, and these patients during the presentation can show any of those features. For example, some patients present predominantly with these thick folds, and in that setting, the clinical diagnosis, endoscopic diagnosis, and even pathologic diagnosis can be meningeal disease. Some of them present predominantly with this kind of polyps, and that time obviously juvenile polyposis will come as one of the differential diagnoses. This particular lesion in this patient was actually a gastric adenocarcinoma. So this particular example shows all the spectrum of findings and complications that these patients can have in the stomach. Meningeal disease or hypertrophic folds, juvenile polyposis, and some of these had dysplasia, and this was actually a adenocarcinoma. This is the high power to show those juvenile polyps, which look like finger-like projections sticking out from the gastric mucosa. And this was the cancer, which actually you can see is a growth that has got ulceration. And if you had a chance to feel it, this was firm and friable. Histologically, there were again variety of changes in the stomach that one could see. This is a markedly expanded lamina propria with a lot of edema. You can see a lot of hemorrhage in the background. The epithelium is foveolar gastric type. It is completely disorganized. There are many cystically dilated glandular structures that have luminal secretions. The lamina propria, in addition to the edema, has inflammation as well. This is the higher magnification to show the hyperplasia of the foveolar epithelium, and this kind of foveolar hyperplasia is the basic pathology that makes those folds look very hypertrophic. And here you can see the edge of one of those polyps as well. This is another area from the same stomach. Here the folds that look very thick are because of this kind of foveolar hyperplasia and a lot of lamina propria edema and inflammation. So when you had seen this case, based on what I showed you, the differential diagnosis included juvenile polyposis, Meningeal disease, Cowden syndrome, probably less likely, Cronkhite-Canada syndrome certainly is in the differential diagnosis. Okay, so as I mentioned, this patient had undergone a total colectomy 20 years ago, and when we tracked down that colectomy and got the photographs and everything else, this is what it was. So this is the entire colon. This is the this is the rectum. This is the cecum and ileocecal valve. There are numerous polyps. They were mostly concentrated around the transverse colon, varying size polyps, some very tiny and small, some very large and pedunculated polyps. And the common feature was that most of the large polyps appeared very inflamed and red, and that was because of a combination of ulceration and inflammation in those lesions. This is a close-up to show those polyps. Again, pay attention to the kind of inflamed and ulcerated nature of these lesions. The colonic mucosa, which is intervening these polyps, appears largely normal. This is the histology of one of those polyps. You can see the ulceration of the surface epithelium. You can see the lamina propria is packed with inflammatory cells, which is generally a mixture of lymphocytes, plasma cells, and even neutrophils. You can see the disorganized crypts. You can see dilated crypts, and you can see some lymphoid aggregates over here. The key thing to recognize is that at least this one is non-dysplastic, and dysplasia is not the sort of diagnostic feature. It can develop on top of these kind of features, but by and large, these polyps, as they begin or they start with, are non-dysplastic in nature. And this is the key, a typical juvenile polyp. I'm sure you see this kind of polyps in pediatric population on regular basis, and do not kind of cause any diagnostic issue or problems. This is a higher power to show you that once these crypts get inflamed, they can look very reactive, lose mucin, and sometimes when you don't have the full clinical information, you can sort of mistake this for an inflammatory lesion of some sort. This is the key feature of these polyps. This is the crypts get dilated, often have luminal secretions. They can also have a lot of inflammatory cells, what we call the crypt abscesses. And because of this, these polyps also get the name of retention polyps or inflammatory polyps. These polyps in the syndromic form can also involve the appendix. This is one example of an appendix involved by juvenile polyp, which is identical to what I showed you in the colon. This is the high power to show you the key features, which is presence of the cystically dilated crypts that contain luminal secretions or inflammatory cells, and the lamina propria is expanded by inflammatory cells as well. And again, these are non-dysplastic polyps. The key thing is that when some of these lesions are biopsied when they're small, may not be that easily diagnosed. And this is example of one of those things. So this is a biopsy of one of the smaller lesion, which is sessile. And you can see that by and large, most of the colonic mucosa appears relatively normal. You can see some edema, maybe some inflammation, some crypt disorganization. But if you see something like this, you are not going to pay much attention, and you are not really going to make a diagnosis of polyposis syndrome. On this side, you can see the features as just beginning to appear. The crypts are getting a little bit dilated. They have luminal secretion, and there is little more lamina propria inflammation. So some of these early lesions are fairly easy to miss and do not have all the characteristic features. But again, if you know that these are polyps in a patient, and there are many of those things, I think you can certainly come to the conclusion that this is likely juvenile polyposis. This is just the higher magnification of that particular lesion to show you the areas that have little more of those typical features with the cystically dilated glands and lamina propria inflammation. These lesions, as I mentioned, can develop superimposed dysplasia and the carcinoma. This is one of those inflammatory polyps, which you can see the features on this side, but you can see on this side dysplasia has evolved in this lesion, and actually this is becoming an invasive carcinoma. This particular patient, as I mentioned earlier, had colectomy, then had total gastrectomy, and subsequently he was also found to have polyps in the small bowel, which eventually evolved to small bowel cancer. And eventually this patient had only esophagus and some part of small bowel and inner canal left. And I think I've lost follow-up on this patient for last few years. Don't know what happened to him, but I can understand his life would have been very, very difficult given that he had lost most of his GI tract. These patients do have increased risk of cancer in the GI tract, mostly in the colon, but they can develop cancers in the stomach and small bowel, as I showed you in this particular case. And management of these polyps is when they are few or solitary, you just remove the polyps. Once they develop multiple lesions, and you do have a family history of juvenile polyposis, when they're young, generally they're managed with simply surveillance and removal of those polyps as they appear. However, at certain point of time, based on the fact that there are multiple polyps, or if some of them develop dysplasia, a prophylactic colectomy has to be considered. Move on to the other polyposis syndrome that I think most of people are familiar with, because this has many other interesting characteristic features, which we call the Peutz-Jeghers Syndrome. This is autosomal dominant disorder, again not very common. Men and women are equally affected. It typically occurs in the second or third decade of life, and the polyps generally present in small bowel or large bowel, and clinical presentation is often with intussusception. Overall, the polyps can occur in any part of the GI tract, small bowel, colon, or stomach. And the characteristic feature that often people remember associated with this syndrome is the mucocutaneous pigmentation. These patients do have increased risk of cancer, and we'll talk about that in a short time. So this is something that people do know right from medical school. This often appears in multiple choice questions and everything else, and something that is interesting in this syndrome. Patients have this very typical hyperpigmented lesions in the oral region or mucocutaneous junctions, and you can see them on the face. You can see them in the palm of the hands. You can see in the soles of the feet. You can see even the perianal and genital area as well. These are very rare in the intestines. And the interesting thing is that these tend to fade away after puberty. And because they tend to fade away after puberty, sometimes when you see in older patients, this may not be as striking and can be easily missed. However, this is a very characteristic feature of this syndrome and present in over 95% of the patients. So again, illustrating this with a case example. This was a patient who was 23 years old, presented to the emergency department with abdominal symptoms, and he had similar symptoms that were intermittent and had occurred for the last 2 to 3 months, and eventually he was found to have intussusception that required resection of the lesions with some repair. He had an history of intussusception even at the age of 2 years. So in this particular patient, this was not a secret. The diagnosis had already been made, but the case is still very interesting and typical to illustrate. The endoscopy, as you see here, showed polyps in the stomach, in the duodenum, later in the colon as well. As you can see, the lesions are sessile, small to very large, as you can see here in the colon. Eventually, the patient underwent elective resection of the gastric polyp as well as the small intestinal polyp, and later right hemicolectomy for some of the larger colonic polyps. These are the gastric polyps, again varying in size. The surface, as you can see here, has normal lining gastric mucosa, and this you can contrast with the red inflamed mucosa in the juvenile polyposis. This is the polyp in the small bowel. Again, note this is a large polyp which is pedunculated. Also note that the background mucosa really looks normal otherwise. This is another one of those polyps. This one looks slightly inflamed, as you can see, but it's still not ulcerated. This is also pedunculated polyp. This is a cut section of one of those polyps, again to show that this is the sort of primarily a mucosal lesion. You can see the muscle layer coming here. The muscle is slightly disorganized, and gross findings is difficult to see the characteristic feature of this polyp, but at least you can see this is a mucosal lesion. This is a low power view of this polyp, which shows a mucosal proliferation, which is seen in some form of lobular disorganized epithelium. But the key feature to note here in low magnification is the presence of this muscle fibers that go in between these lobules of disorganized epithelium, in a pattern this is which is described as arborizing smooth muscle, almost like a main trunk of the tree and the tree branches that go in between. This is a higher magnification to show the epithelium, which is again proliferative, non-dysplastic, but the key feature here is the presence of bundles of muscle fibers going between these lobules of proliferating epithelium. Again, another example from a polyp to show you this kind of arborizing smooth muscle bundles between these lobules of non-dysplastic epithelium. The epithelium is slightly disorganized, but if you look closely, they otherwise look fine. They are composed of normal epithelial cells inherent to that particular site. The interesting thing about some of these polyps, and I have seen quite a few of those that have this finding, and it can be very challenging. This is from a small bowel lesion where you can see the epithelium proliferating, and some of the epithelium sort of dips down into the muscle layer. And in this particular example, you can see this kind of epithelium that dips down almost reaches the fat. And when you see something like this, the first thing to think about, or what one would get worried about, is presence of invasive carcinoma, and this is not. These are just islands of pseudo-invasive epithelium, which does occur not infrequently in these polyps because of various traction and torsion that these lesions can undergo, and merely presence of this non-dysplastic epithelium should not make one diagnose cancer in these cases. This is a lesion in the colon, and in colon you can also see this arborizing smooth muscle that sort of separates these lobules of disorganized epithelium. The reason I'm showing this colonic lesion is that the arborizing smooth muscle is best appreciated in the small bowel lesions. In colonic lesions and gastric lesions, sometimes this is difficult to appreciate, and you have to really pay close attention to the architecture of these polyps. These polyps can also develop dysplasia and cancer, as shown here in one of the lesions, where you can see the epithelium now has nuclear atypia, nuclear stratification, and all those features that we characterize as being dysplasia. So in this particular patient, there was no family history of any polyposis syndrome, and was subsequently sent for genetic testing. And here is the panel of genetic tests that we generally do in patients suspected of any polyposis syndrome. This includes about, I think, 17. This may have expanded a little bit more now, but it contains all the major genes that are associated with various polyposis syndromes. So in this particular patient, mutation in STK11 gene was found, which is the typical genetic mutation associated with Peutz-Jeghers Syndrome, and a diagnosis of Peutz-Jeghers Syndrome was sort of made. And in a case like this, where you have all the typical features, probably don't need this mutation for the confirmation of diagnosis, but it's always good to have that. The mutations are seen, depending on the study that you read, between 50 to 90% of these patients. And again, like other polyposis syndromes, the diagnostic criteria have been established, which, as you can read here, are combination of family history and presence of one or more of these Hamartomatous polyps that have typical histologic features. You should note that the mucocutaneous pigmentation is an important feature in the diagnostic criteria, and as I mentioned earlier, is present in most of the patients if looked carefully. The risk of malignancy in these patients is in the GI tract as well as outside GI tract. In the GI tract, again, all sites have some risk of cancer, in which the colorectal cancer is probably top the list with about 39% risk. In the non-gastrointestinal locations, breast is on the top of the list in ranging from 30 to 55% of the patients. The interesting thing about this syndrome is that there are certain kind of tumors that have high predilection for this syndrome. In fact, if you see any of these tumors in your routine clinical practice, you should investigate whether the patient has got Peutz-Jeghers Syndrome or not. And these tumors include so-called adenoma malignum or so-called minimal deviation adenocarcinoma of the cervix, and in the ovary, sex cord stromal tumor with annular tubules or so-called SCAT. In the testis, the tumor that is typically associated with Peutz-Jeghers syndrome is so-called large cell calcifying Sertoli cell tumor. A brief mention about this syndrome, which is called mixed polyposis syndrome. This is one syndrome where variety of polyps, particularly the hyperplastic, juvenile or Hamartomatous polyps, can occur all together in some combination. This is not well understood, but called mixed polyposis because the polyps, different kind of polyps, do occur all together, and there is increased risk of GI cancer. There are some case reports now of BMPR1A gene or GRAM1 gene associated in couple of patients, and whether this is a variant of serrated polyposis or juvenile polyposis because of BMPR1 mutations, we still don't know. Coming to the last entity on this list, Cronkhite-Canada syndrome, and this is very unique and very interesting syndrome. This is something that was described in 1955 by Cronkhite and Canada in their physicians in two patients with gastrointestinal polyposis and a combination of hyperpigmentation of the skin, hair loss, and nail atrophy. This syndrome, although has a worldwide distribution, a lot of cases actually have been described from Japan and the area around that region. Is a wide, age range during clinical presentation. But again, if you note the main difference from other syndromes, that many of the patients actually present at older age. The mean age is around 60 years, as you can see, which is very unusual for most of the inherited syndromes that we discussed earlier. This has no inheritance pattern and has no genetic predilection. The patients typically present with diarrhea and malabsorption fairly acutely, and have rapid progression of the symptoms with secondary features developing, which include alopecia, skin hyperpigmentation, patchy vitiligo, onychodystrophy, edema, electrolyte disturbances because of the diarrhea. Same thing leads to tetany, and deficiencies of nutrients lead to glossitis and even cataract. And these are the nail changes that are typical of this syndrome, the hair changes that I mentioned, and hyperpigmentation that I mentioned. And endoscopy, multiple polyps are found that involve the entire GI tract except the esophagus. And pathology of these polyps is again very interesting. These generally look like just presence of inflammation and edema in the mucosa, and often the surface is intact, and the polyps generally, if you have to draw any similarity, they're probably the closest to the juvenile polyps that I showed you, with the lamina propria edema, some inflammation, some disorganization of the glands, and lack of any dysplasia or adenomatous changes. And this is something that we have also now recognized, that unlike the other polyposis syndrome that I showed you earlier, this is not associated with any underlying germline mutation in any oncogene or other genes. it is currently believed that this is probably a unusual immune response to a particular infection with some disturbance of the intestinal mucus. It's probably some form of an immunologic disorder combined with some form of abnormal reaction to microbes. People have also shown that there is presence of increased IgG4 cells in the lamina propria in this condition, although this does not fulfill all the criteria for IgG4 associated disease, but this is certainly an interesting finding that has been frequently seen in these patients. These patients, if they are untreated, the mortality remains high, 50 to 60%. Some do have spontaneous remission. But as I mentioned, this is not a polyposis syndrome. This is some form of an abnormal immune reaction. So a variety of things that are tried, like antibiotics and steroid, can result in resolution of the entire clinical picture. Some of the resistant cases may require surgery, but I'm seeing less and less of this now. In our clinical practice, the cases that we have seen in last few years, all have responded very well to antibiotics and steroids. The other major thing in these patients is supportive care for chronic diarrhea and various nutritional deficiencies that result from that chronic diarrhea. Again, these patients do not have any underlying germline mutations associated and are considered not to have any increased risk of malignancy. However, some cases do have malignancy identified or adenomas identified at the time of polyposis, and it is believed that this is likely coincidental because many of these patients did not undergo any colonoscopy or something else, or some other screening procedure prior to this presentation, and many of the patients that we have seen came from poor socioeconomic status where they did not have good health care. So the polyposis and the carcinoma were both diagnosed at the same time. So going back to the case that I presented, if you remember the histology, it was fairly nondescript. It really looked like inflammation with none of the other things that we discussed in other syndromes. This was purely an epithelial proliferation. There were no dysplasia, no arborizing smooth muscle. And if you were to pick of all the polyposis thing that I mentioned earlier, this will be probably best described as either inflammatory polyp or juvenile type polyp. When you put this thing together with the clinical, and which is very important, this patient was 80-year-old female, which is very atypical of other polyposis syndrome, had long-standing diarrhea, had hair loss and nail changes, which were kind of described as onychodystrophy with significant weight loss, and has diffusely scattered polyps throughout the GI tract that spared the esophagus, and all of them presented at the same time. Other key thing which is typical of this condition, but nobody really pays attention to that before, and sometimes the endoscopists also don't think about it, is that mucosa intervening between the polyps is never normal. And if biopsies are available from the intervening mucosa, it shows identical changes to what you see in those polyps. So basically, this is some form of inflammatory disorder which presents with multiple, polyps, bringing all the polyposis syndrome in the differential diagnosis. In this particular case, based on all those things, the final diagnosis was Cronkhite-Canada syndrome. This is something which is again not common. I have probably seen about 3 cases in my practice for last 30 years in pathology. Again, the first case was difficult to diagnose and required a lot of input from everybody. But once you learn about the syndrome, the second and third cases do become relatively easier. In fact, for the last 2 cases, we were the one as pathologists who told the clinician, think about this and go and check everything else. And eventually that's what happened. Anyway, the last few slides are just for the sake of information. These are all the polyposis syndrome that are common and one should know about. And the associated genes are listed along with the typical clinical or pathologic hallmark of each of the polyps with associated cancer risk. This is just another chart just to show you a broader list of all polyposis syndrome, including the Adenomatous polyposis and serrated polyposis, as well as the Hamartomatous polyposis. And this is a flow diagram to show how we approach based on initially what you find on pathology, the kind of polyp that you deal with. And I think the first distinction is to make sure that these polyps are numerous versus less numerous, and those that are less numerous are considered non-polyposis, although you still have polyps in those that setting. And this largely is represented by Lynch syndrome, or so-called familial colorectal type X syndrome. And the other polyposis, where you have numerous polyps, are largely divided into adenomatous, hamartomatous, mixed, or serrated polyposis. And this is what we have already discussed, and these are the main genes that are associated with each of those syndromes. And one thing which you have to know now is that while earlier these were based primarily on the clinical pathologic findings, now for the diagnosis of this polyposis syndrome, clinical findings still very important, family history is still very important, pathology obviously very important, but genetics is becoming more and more important these days. Most of the centers, tertiary care centers nowadays have gene panels that are available where you can look for this genetic diagnosis in these patients, which in many cases is the final thing that kind of clinches the diagnosis. And I think some of the atypical cases, this is a very important investigation that forms one of the key things to know about. Eventually, like anything else, I think it's the clinical pathology correlation, as I showed you in this particular case, which is Cronkhite-Canada syndrome, where one has to not only look into the histopathology but also the clinical finding this patient. In this particular syndrome, as I mentioned, there is no known genetic mutation, and it is not a genetic disorder. So with that, I would like to stop here and show you a nice kind of building, which is the palace or the Rajbari. This is from my hometown in Agartala, and this is my family from our last visit there. So with that, thank you very much, and I'll be happy to take any questions from people who are listening or are online, either by your verbal questions or online chat questions, whichever way. Thank you.
Thank you so much, sir. It was a very comprehensive and lucid presentation. Amazing photo micrographs. And we have a few comments, and there's a question from Dr. Vishal Rao. I think this is regarding the juvenile polyposis case who underwent the polypectomy. He's asking, has many trials a disease presented as mimicker of adenocarcinoma on biopsy?
Yes, I think that's a very good question. I think I would say one thing, which some of the people still may or may not agree about, but most of the cases of menetrious disease that people had diagnosed, before all the genetic things became available, have turned out to be actually juvenile polyposis. So I would say that a typical case of just menetrious disease I haven't seen in the last 20 years. And I have asked many of my other friends and colleagues in other centers, and they also haven't seen. And what has happened is that whatever was thought to be as menetrious disease, once they were all tested, they were found to be the gastric manifestation of juvenile polyposis. So yes, on one hand, when you see something like this, and the histology is what I showed you with the foveolar hyperplasia and lamina propria edema and inflammation, you can certainly consider menetrious disease as one of your differential diagnosis. But if the genetic test is available, and if you know the other features in that particular patient, you must try to exclude the possibility of a juvenile polyposis. One thing also I'll mention that among the juvenile polyposis, I didn't say in my lecture, there is a variant which is limited to gastric manifestation, where you have isolated involvement of the stomach and no involvement of small bowel and colon. And that can again be easily missed if you don't know that this can happen, and that can be again diagnosed by genetic mutation. Another interesting finding with those things is that some of the patients actually have coexisting hereditary hemorrhagic telangiectasia in those patients, HHT. So association of juvenile polyposis and HHT is also known, and if you have any clinical features pointing towards HHT, again, you should consider juvenile polyposis as a diagnosis.
Right. Thank you so much, sir. Sir, there's a question. So were other family members affected for this patient?
No, in this patient, to the best of our knowledge, we did no. None of the other family members were involved. So this was probably de novo mutation.
Right. And Dr. Manoj Chaudhary has commented that it was a rare opportunity to go through both common and rare diseases, and excellent photomicrographs and a very good discussion. So
thank you. I am also looking at the chat, and now I can see if there are any other questions. Yes.
So I thought the slide for the appendix involved by juvenile polyposis was really something very nice. And one surprising thing is that even in the US, past histories are not forthcoming. Like the past history of colectomy wasn't readily available to you. So though the documentation of the Ross photograph from a 20 years back case was really good. I mean, it looked as if it was clicked very recently. Very nice.
I think nice. Again, I think what I meant was the history was probably there, but as you know, most of us, when we get the cases, to us the history is not available at that time, and you have to dig somewhere. And that particular case that I showed you was actually, I encountered that case, I think in around year 99 or something, or 2000. So it's almost about 20 years ago. And at that time, electronic medical records were still not common. So, we had to dig down to get all that history. Nowadays, it's much more easier to get all the medical history and everything.
Sure, sir. Sure. Wonderful presentation, and thank you so much for sharing your knowledge and showing us these lovely cases. Thank you so much, sir. Dr. Nadeem, sir, any inputs from your side?
No inputs. I think we are all mesmerized with this talk. Excellent presentation. Dr. Dhanpat sir is known for his wonderful presentation. He has been a wonderful teacher all throughout. He was my immediate senior resident, and he is the one who has taught me all the pathology that I know. So
please don't embarrass me. No, I think it's been great to be associated with everyone. I see in audience Paramita is also there, who is a wonderful pathologist, and we have got to know her as well. Paramita, can you hear us? I think probably you can.
Yes, sir, thank you so much.
So good to see you all there in the audience. I see Shashireka, Mamta, quite a few other people. I'm sure I've met some of you during my visits, and now again, it will be a pleasure to see you all in real person next time when I visit India. May happen as soon as February or April, but let's see.
Great. If there are no more comments and questions, thank you so much, sir, once again for a wonderful presentation, sharing, though the time is less and we would love to listen to you and it could really go on. Thank you so much. Thank you so much. Thank you.
Okay, take care.
27th is the next talk with Dr. Dhanpat Jain, and that time we'll be talking about the issues related to biliary tree. So that would be very interesting. That would be very dynamic talk. So we'll all be there to listen to that. Thank you, Dhanpat sir. Thank you, everybody. Thank you, Dr. Poonam, for
so much, sir.
Moderating it so well. Thank you. Good night, everybody. Take care. God bless you. Bye-bye.
Thank you.
Thank you, sir.
Bye-bye.
Thank you, sir.